Exciting results were presented today in melanoma settings, as Caroline Robert from Institut Gustave Roussy described.
We have three studies that have been presented. Two concern the melanoma with BRAF mutation. One study with a little bit less than 400 patients evaluated single-agent vemurafenib, which is a BRAF inhibitor, as compared with placebo for patients with BRAF mutant melanoma who have had surgery for a thick ulcerated primary, stage 2C, or for lymph node metastasis after resection. The main endpoint of this study has not been reached, in the sense that the relapse-free survival of the patient in the cohort beginning with stage 3 did not reach significance. Although there is a trend, there is a decrease in the risk of relapse, but it's just not significant. In the cohort of the earlier disease, there is an effect, a significant effect, with decrease of the risk of relapse. This trial globally is negative. We have to say that the single-agent anti-BRAF we know now is not the best choice when we want to treat a patient with a BRAF mutant melanoma. We know that it's much better to target with the BRAF and a MEK inhibitors. And this is the second study that I want to talk about, COMBI-AD. And here we target with anti-BRAF plus anti-MEK, dabrafenib plus trametinib. Here we target this BRAF mutant melanoma after resection of lymph node metastasis. And this is also compared with a placebo, and here we have more patients. We have an effect, a very significant effect on relapse-free survival with an hazard ratio of 0.47. So this is a very strong effect. This is a major result in the field. The third study now concerns the melanoma regardless of BRAF mutation, because we deal with immunotherapy. Ipilimumab was the control in this trial. So in this trial, as opposed to the other two that I talked about, we have an active arm in the control arm, which is ipilimumab at 10 mg per kilogram, the 4 infusion separated by 3 weeks interval, and then 1 infusion every 3 months. The arm that is supposedly to be the active one is nivolumab, anti-PD-1, with a 3 mg per kilogram normal dose every 3 weeks. And here again we have a very positive trial. We don't have the median relapse time because it's not reached. Here the follow-up is less long, we are less than 2 years, but we have an hazard ratio of 0.65, meaning that we have a decrease of the risk of relapse of 35%. The field is totally changing. So in terms of changing our practice, yes, you can say that will change our practice.
The IDEA collaboration, presented earlier this year, showed the non-inferiority of a 3-month course of chemotherapy in comparison to 6 months. How will these results impact on clinical practice? Alberto Sorbero from Ospedale San Martino illustrated the conclusions which emerged from a dedicated Congress session.
These conclusions are based on the fact that we distinguish two types of patients. The fighters, who are those who want any benefit, no matter the toxicity, from the fatalists who say, well, if I have a lower toxicity, I'm ready to go for 3 months only, and I'm ready to lose 1 to 2%. The session concluded with a very straightforward message. If the patient that you will have in front of you is a fatalist, it is not worth going to 6 months. And there was a consensus that 3 months is okay, no matter whether he is high risk or low risk. If you have a fighter, we can distinguish 3 conditions. The first is the low risk. By low risk, T3 means T1, 2, 3, and 1. And in that case, they should get K-pox for 3 months. And there was a unanimous judgment on this conclusion. The second condition is within the high risk stage 3, that accounts for the N2. And there we were split. Most of us were in favor of doing 3 months and not 6 months. A few voted for 6 months. The third condition is the condition where the patient is a fighter and is a high risk, and is a high risk because of T4. And here the judgment was unanimous, 6 months of treatment, either FOLFOX or CAPOX.